Well, good afternoon, everybody. My name is Kim Holland, and I'm delighted to be the moderator here for this great panel. I am a relatively long-time, few-year NASI member, so it's my pleasure to add my welcome to you today, and thank you all for letting me be here. I'm a newcomer to Washington, D.C., however, so as way of introduction, I would have you know that as a small business owner, I bought health insurance, and as an employee benefit consultant and broker, I sold health insurance. And as the regulator of insurance in the state of Oklahoma, I regulated the health insurance industry. And now as the executive director of state affairs for the Blue Cross Blue Shield Association, I work for a health insurance organization. So I have had the privilege and challenge of viewing the health insurance and our healthcare industry from virtually every angle. And I remain in awe of its complexity and its potential. So it is really a treat for me to first work for an organization that is as committed as each and every one of you are to ensure that all Americans have access to high quality and affordable health care as well as health insurance, and to join my friends again here with this panel. So just to tee things up a little bit, I would offer up to you that the Patient Protection and Affordable Care Act is perhaps the most controversial piece of legislation that's been passed in recent history, and it's likely to be a key issue in the presidential debate, if not the election. While we might agree that the ACA is not a perfect solution, its enactment has raised the critical issue of our country's costly and inefficient healthcare system to the forefront of the national discussion. While the debate continues about the role of the federal government in providing a solution, we can't ignore the tremendous social and economic reality of the program, and we certainly heard a lot about that today. So I'd add to John Rother's statistics and say that uncompensated care in 2008 according to Dr. Berenson's organization, the Urban Institute, totaled 2.2% of total health care spending, which equaled $56 billion. The Families USA estimates that the cost of providing care to the uninsured added an average of $1,502 annually to the health insurance premiums of every family of four in the United States. In terms of the implementation of the ACA, the Associated Press recently found that 13 states have adopted a plan for implementation, but they're home to only 1 in 4 of the uninsured. An additional 17 states are making some headway, but it's not clear that they'll succeed. And of the 20 states that are lagging behind, they account for the biggest share of the uninsured, 42%. I can tell you in my home state of Oklahoma, 20% of our population was uninsured. 1 in 5 of our citizens were unable to access the health care system or afford to pay for, if they could access it, unable to afford to pay their bill. In 2009, Peter Orszag, who, as you will recall, was the former director of the Office of Management and Budget, did an interview on NPR, and he stated that estimates suggest that as much as $700 billion a year in healthcare costs do not improve health outcomes. They occur because we pay more for care rather than better care. And then supporting, and I will confirm John's earlier statement by way of a quote from Jack Wennerberg, of Dartmouth Center for the Evaluative Clinical Sciences, and he did say that up to a third of the $2 trillion that we now spend annually on healthcare is squandered on unnecessary hospitalizations, unneeded and often redundant tests, unproven treatments, overpriced cutting-edge drugs, devices no better than the less expensive products they replaced, and end-of-life care that brings neither comfort nor care nor cure. So as we approach the 2-year anniversary of the signing of the Affordable Care Act, have we made any progress? Will we make any progress? So here to provide their thoughts on the ACA in Adolescence is an outstanding panel with a wide range of experiences as well as expertise. So I will introduce them briefly and then invite our first panelists up. To my immediate left is Gretchen Young. She is with the ERISA Industry Committee, and she's going to start off our panel today with the large employer perspective. What process do employers undertake to develop and select a competitive benefit package? What does it cost? Why do employers offer health care benefits? Well, they stopped doing so under the ACA. How does the ACA impact large employer plans from a benefit as well as cost standpoint? And then we'll hear from my good friend Joel Ario, Managing Director of Manatt Health Solutions. He's most recently with the Center of Consumer Information and Insurance Oversight, and was prior to that both the Pennsylvania and Oregon Insurance Commissioners. Joel likes to move around a lot. Next, what he's going to offer to us is a snapshot of where states are in their progress to enable health insurance exchanges, a very important part of the Patient Protection Act. And in spite of its politics, all but a couple of states are in some stage of exchange development. What are the challenges? What are the opportunities? What does state flexibility look like? And what happens if the Supreme Court rules that the mandate is unconstitutional and severable? And then we'll wrap it up with Alan Weil, who is the Executive Director of the National Association of State Health Policy. And he'll go beyond the political rhetoric and exchanges to discuss the challenges and opportunities under the ACA to improve America's healthcare system. What delivery system changes are essential to accomplish the goal of improving cost and quality? What are the biggest barriers to state implementation of the ACA? So I would invite you to refer to your packets, which includes full bios on our esteemed colleagues here today. And we'll give each panelist 12 to 15 minutes roughly to make their remarks and then invite you to join this conversation. So Gretchen, please join me.
Thanks so much. As the representative of large employers here today, I'm really happy to be going first because I planned to hide under the table during the Q&A session. Just a little heads up. So I'm talking about, is this how you advance this? I'm going to talk about the existential angst of large employers. I really don't know what that means, but you know what it conveys for me is that picture of Edvard Munch, the scream, he's going, ah! That's kind of how we're approaching this from the large employer standpoint. So what I'd like to talk about first is the ERISA Industry Committee, large employers, mega large employers. I do the health policy work for the trade organization. That's who I am. So that was just a little brief introduction. What were our preconceptions at the start of PPACA? Like what were we looking at and what were some of our concerns? Well, one of them was, we actually thought we were providing pretty good health care to our employees. And we were a little concerned that this new system, these new changes would not be helpful. They wouldn't be helpful either in terms of the administrative challenges we faced or the additional costs that we would bear. We were also very uncomfortable with the thought of everybody saying, well, as soon as 2014 comes around, you're going to dump all of your employees into the exchanges. Truthfully, most of our members are pretty paternalistic. They like the idea of providing quality health care to their employees. They really aren't anxious to dump them into an unproven system, particularly considering the tax treatment of insurance provided through employers, insurance provided without that tax break. And a second corollary of that, I think, is that there was an issue on, well, if you say you did get rid of your health system altogether with all the headaches that entails and all the costs that entails as well. So you'd be giving a lot of money to the federal government, either in penalties or some other way, over a system over which you had no control. And I think many employers now feel that they provide really very good health care, and one of the reasons is they take an active part in choosing the providers and determining how it will be provided to their employees. I think in terms of the health care bill, the PPACA bill as a whole, we were very happy to see some inroads into cutting costs and expanding coverage. Certainly we would have liked a much greater emphasis on reducing costs. We were happy to see things like the expansion of Medicaid, because eventually we hope that will eat away at the cost shifting to employers. So what I want to do is I want to just give you a flavor. I'm obviously not going to go through all the rules and regulations and all the things we don't like about the bill. That would take forever. So I'm just going to talk, about an overview. And the way I have actually thought about doing it is, really one of the major themes right now is uncertainty for us. It's uncertainty over, how are the regulations all going to come together just on a macro level once they're all out there. Obviously, what is the Supreme Court going to do? What do the November elections hold for us? And then the second part of this is, I just want to pull out a few of the major regulations we've been dealing with, just to try to show you how our preconceptions about additional costs and administrative challenge play out in, say, 3 or 4 regulatory arenas. And then last, just talking about a little bit about tax reform something that might come down the road. So the big question is, what's going to happen to the Affordable Care Act? First of all, it could have been dismembered by Congress. I think we've seen so far that that has not happened. It will not happen before the November elections. You know, with the House in Republican hands and the Senate in Democratic hands, the House has passed repeal. It just dies in the Senate. It looked as though initially that there might be a movement towards defunding certain parts of PCCS, withholding money from HHS or from the IRS or one of the other regulatory agencies, but that seems to have fizzled out as well. I think people are waiting more now for either big change from the November elections or from the Supreme Court. Defenestration, remember that from high school history? That's when they throw people out the window. I just like the term. So clearly it could be defenestrated, is that a verb? It could be defenestrated by the Supreme Court, I'm going to get into that in a section, or by the November elections. And I'm sure, I think John Weiler was talking about the debates. We've all heard Romney say, the second day I'm in office, I'm taking out the Affordable Care Act. Well, really, that cannot happen. And just for a short explanation of why that's true, he doesn't have the power from our high school civics class. He can't actually override both parts of Congress. He also can't do it by executive fiat. So that is just not a possibility. What I think is, and just to say, there are waivers that will be available to states in 2017, and probably Joel and Alan will talk about those. They're not available until 2017, and even if the states wanted to do it, they're only able to be exempt from things like the qualified plan rules, the exchanges, cost share and so forth, and they have to substitute for that some other system that would be equally affordable and equally comprehensive. So maybe if Romney got rid of the Affordable Care Act, still there'd have to be something else in this place, but it's not going to happen initially. I think that it's certainly, of course the whole depends on whether the Republicans take control of the House, the Senate, and the White House, and within the Senate if they get 60 votes to defeat a filibuster, as to whether or not they can take out the Affordable Care Act altogether. But there's so many nuances and so forth. We're going to have a meeting of my group in March. One of the sessions is going to be on what if the Supreme Court lets it go, if the Republicans take the House but not the Senate. There's just so many different streams you can go down. It's really difficult to see what could happen, particularly given the fact that some Republicans like part of the act. They like the, what I call the slacker rules, letting your kids stay on your plan until you're 26, while you're paying for their cell phones. I like that. I've got 2 of them. So there are parts that they would like to keep in effect, and that's certainly a consideration as well. And that's what I call the salvage operation, what is going to happen in the November elections. So Supreme Court, obviously, but it hasn't escaped anybody that the Supreme Court has taken upon themselves the idea of deciding on the constitutionality of parts of the Affordable Care Act. They're going to have oral arguments at the end of March. There, as I'm sure you've seen, the historic 5.5 hours of oral argument. Never before in our lives have we ever had 5.5 hours, which is kind of funny. And they're really going to look at 3 or 4 different questions. One, the first one they're looking at is it really too early to judge the Affordable Care Act in its entirety because the issue is not ripe under the Anti-Injunction Act, so you can't do a tax challenge. So you can deal with that. That actually could put the whole thing off until April of 2015. I personally, my 2 pits, that's where I think they're going. You heard it here first. Then the other questions that we've been more actively dealing with is the individual mandate unconstitutional? And if it's unconstitutional, does it take out the rest of the act with it? That's a pretty essential concern for us. And then there's another issue on whether or not the Medicaid expansion is constitutional. I guess Alan will probably go into that in more detail. Yeah, all the hard questions. Alan or Joel's going to be taking care of that one. And we're expecting a decision to come down in late June. Although again, as I said, if they think that the Anti-Injunction Act is applicable, then they could put the whole thing off until April of 2015. Okay, so what is the role of large employers? Now I like to put up incendiary things. But truthfully, there are elements of all of these I think employers feel very strongly. When I have a meeting with my employers, and these are people who are head of HR, and they are devoted to the cause. Let me tell you, they call me 3 o'clock in the afternoon on Saturday saying, can we discuss the uniform benefit summaries? I always say, yes, sure, happy to do this. But they'll come back and say, tell me again why it is that I always feel like we're the villains in this. We provide really expensive, really good health care. Why is it we always seem to feel that the rules are written because we're the bad guys? So that's one of our reactions. I'm going to lay out these little themes, and I'll pick up the themes when I'm going through the guidance. Another one is employers as an unwelcome presence between you and your doctor. You've all heard these ads on television, don't let anybody come between you and your doctor. I would like to be between you and your doctor. I'm sorry if there are any doctors here. I would like to stand between you and say, wait a minute, let's talk about the cost. That's one of our themes. Let's talk about the cost. And then there's my favorite, employers as cash cows. And the problem here is that, again, we'll go into more of this in the regulations themselves, but it seems to be that whatever rules come out always costs us more money and more administrative complexity. And our constant refrain is, particularly given the fact that rising healthcare costs take up all the slack, 5 or 6, 7% a year in rising healthcare costs, we don't have extra money to devote to healthcare. The money we have now is this amount. If you cause us to pay more here, it's going to come somewhere. It could be in fewer benefits, it could be in higher copays for employees, but it's going to have a ripple effect. So this is not something where we can just continue to throw more money at it. And of course, why would employers want to provide good health insurance for their employees anyway? The two words we usually come back at people with are recruitment and retention. People want it. Who here does not want to go to work for an employer that offers good health insurance? It's essential. It's also essential at retaining your employees. Those are the two basic rules of why we keep good health insurance. I think another aspect of it is that for us, and this is one of the reasons we're getting more into the wellness and prevention sphere, a healthy workplace, one in which they don't have to worry about the health of their children, is a more productive workplace. So I think we have very solid business reasons, in addition to any other moral or ethical reasons, of why we want to continue to provide good health care, and that's why we're in the business of doing it. So implementing the guidance, the good, the bad, and the ugly. These are actually Jeopardy categories, so I'm going to go with the good for 100. Actually, truthfully, what I really wanted to do for this slide was, has anybody here not played Candyland, that dreadful game that you never, ever end? You only end when your kids go to college. What I wanted is to have this whole Candyland thing based on healthcare reform. You'd be going 2 steps and you think you're fine, and then you slide down uniform benefit summaries. Then you go a little while over here, and then it's the exchange regulations. You go up here, you just get the idea, but it's beyond my skill level. So I just want to really talk about some of the regulations. I don't really dwell on the good, not because there aren't any, but because I'd rather talk about the bad. There are things like the ERP program. What was that? Employee retiree reinsurance, where we actually got money for our retirees. That was a very good thing. But just to kind of demonstrate again what it is that drives us nuts with the ACI guidance. One of the first ones is uniform benefit summaries. Now, this is a very, very good idea for the individual insurance market, because people need to know what they're buying and to be able to compare across plans. It's a lot less good, I think, for the large self-insured employer market, where we think we already provide really terrific guidance to our employees on the benefits that are available to them from that company. And I'll say, for those of you who ever work for the government, at least in the DC area, the Washington Consumer Checkbook people put out this little booklet. It's about this big. It has 100 pages. And you can flip it open and see, cross plans, who has out-of-network, catastrophic coverage. I used it when I worked for the government. That's the sort of thing that we as large providers provide. According to the guidance, which does not yet formally apply to us, but I fear it could, I'm already at my 3-minute mark? No. Oh, no, I'm sorry. Thank you. According to the guidance, we would instead of providing a box that went this way, we would have to provide 4 pages or 8 pages about each continual plan. So like in the federal government arena here, you'd get 180 different plans of 4 pages each. So obviously this is something that we think we already do well, that we don't think would be improved under these rules, and would cost a lot more money. Essential health benefits, another one that, well, actually, maybe I'll just skip that one in view of the time and go on to the exchanges. If anybody's interested in social health benefits, I spent most of my life for the last month or so working on it, but I'll skip it to the exchanges because we're going to be talking about them later. Large self-insured plans don't have as much concern about the exchanges as exchanges, but what we are very concerned about is to make sure that the standards that apply to us are national uniform standards. Preemption is one of our basic concerns. We want to make sure that we don't have to deal with 50 different state rules. We want to deal with one national rule. In terms of the exchanges, we're probably where our basic concern comes out is in the reporting and disclosure. Well, let me just spend 1 minute then on one more piece of the ACA guidance that's problematic for us, and that's the employer mandate. And there it's really more a matter of, we don't know the rules yet, is it going to be this rule, is it going to be this rule? How can we structure our plans? How can we decide what is best for our workforce? Let me just end by saying that one of the other sort of areas of uncertainty that we're looking at now is the uncertainty with this connected with tax reform. And here, of course, one of the discussion points is whether we should eliminate the exclusion for employer-provided health care. We're, of course, not happy about doing that. We can see the parity involved in allowing some kind of tax favor treatment to buy insurance in the individual market. But we're very concerned about that, and we saw, from the election with John McCain that there is certainly a Republican willingness to talk about eliminating the exclusion from employer-provided health care, and that does make us concerned. Thank you very much.
So the most difficult part for me is always making this little thing work. So show me which, I'm hitting that one.
You're asking the wrong person. That's it. Yeah.
All right, so we've got that solved. I can assure Gretchen that in all of our discussions during the year, one of the issues that we always came back to was do no harm to the large group market. I can't promise that it'll end up that way, but that's, I think, certainly people do recognize that the large group market is a workable market, and I'm happy that we started with that part of the market, because now we get into the rest of the market, and I think the story is a little bit different. But I want to start with a little story of my own first. Bishop gets on an airplane after a week out visiting a number of his churches, and he's feeling pretty good about himself. He's opened a new daycare center and solved several kind of problem issues, and thinks he's got a great job, just wants to relax on the plane flying back to his home base. And a college kid with a backpack gets on, ends up sitting down next to him, sees the collar, and just takes it as an opportunity to go into a tirade about the church and pedophilia in the church, and why can't women have the right place in the church, and why do you have all these big buildings in these poor communities? It's just not what we would expect out of one of our highest ideals as an institution. And the kid goes on for half an hour and finally takes a breath, and the priest reaches over, puts his hand on the kid's shoulder and says, "My child, after 50 years in the church, it is so much worse than you can imagine." And that story captures, for me, every job I've ever had. I listen to the people who critique it, and I say, you know what, that's a pretty good critique, sometimes pretty good critique, but I could double down, triple down on that critique. So the point of telling that story now is I'm not going to talk about any of those parts of the world. I'm talking about the glass half full kind of thing, not the glass half empty side of the story. So I'll acknowledge that right up front. Some people have called me Pollyannish, but I think it's a good form of optimism, and I bring a good form of hope to these issues. And I'm going to describe why I think that the exchanges are on a path towards success, and that we can have the same kind of market in the individual and small group market that we have had in the large group market. And I'm going to talk to that around the 6 points on the overview slide here. First of all, setting the stage a little bit, talking about the regulatory framework that we developed for these state-based exchanges in the year I was at HHS under the great leadership of Don Berwick. Then secondly, talk about the political uncertainty that we have this year and how it will continue through, at least through the November elections, hopefully no further than that. Third point is that the states, in spite of all that uncertainty, are making measurable progress. If I had a single kind of foundational experience to my whole year, it would be invariably when there was some bad news in the press about some state political leader saying something bad about what they were going to do in terms of the ACA and progressing on the ACA, I would then get a call from somebody in that state or somebody who was an important stakeholder had a stakeholder relationship with that state going, don't believe what you saw in the paper today. There are a lot of us working behind the scenes that we're going to get things done anyway. And that extends to literally every state. If I was allowed to, I could tell you stories about literally every state where there are people like that working. So there's a big gulf, and that's probably my single most important point to drive home today, between what we hear in the political class as you listen and read about it in the newspaper, and what's actually going on the ground in these states, not only among the career professionals who work in these states and who recognize the tools of the ACA, but also among literally all of the stakeholders that have been involved in healthcare. That assumes that most of the Tea Party people aren't previously involved in healthcare, but other than the Tea Party people, there really aren't strong bodies of opposition to the ACA reforms. So then I'm going to turn into a little more specifics on that. In the last 3 slides, leading states will make a lot of progress this year, and that what they do achieve will be a very important marker for what is going to happen to the ACA, I believe, after the election. Not all states will make it, so the federal partnerships that were introduced in the middle of the year will be critical. And then finally, there will be some reassessment. I know compromise is still considered a very Pollyannish word in D.C., but there will have to be some compromise if we're going to go ahead as a country, not just in this area, but in other areas as well. So turning to the next slide, see if I can execute on this. Oops, 1, 2. See, I can't do it. There we go. State flexibility under federal standards. This is kind of setting the stage. The blue box there, the ACA does put the states in the driver's seat on the exchanges. The House bill won out. The Senate bill won out over the House bill. That was the direction of the ACA, and it continues to be the way the law is implemented. Most recently, we saw it with the essential health benefits. The states have the opportunity to step up and really control the marketplace around the exchanges and the way in which the reforms play out in the individual and small group market if they take that opportunity. So you see there a little timeline. In July, we put out the first regulations, which the theme really was state flexibility. We kept looking for synonyms to flexibility because the word got used so much in what we put out. Then we went to August, and everything is not completely lined up on state flexibility. And so in August, when the regulations were put out around the enrollment and eligibility engine on the front end, there was a different theme there. It was simple and seamless to the consumer. And when you think about what simple and seamless means to the consumer in the context of the exchanges, that does mean a lot of uniformity, very prescriptive rules. Amazon, Google, these things are good for the consumer because they have an incredibly complicated and highly regimented back room I see Jay sitting here in the front table, nodding, works on the Massachusetts end of this, but you have to have a very complicated back room operation in order to achieve a good result for the consumer on the front end. We were always nervous about putting out charts showing some of this complexity. One of my favorites that I saw that Don uses in his speeches about quality improvement has to do with, even if you look at the kitchen of a restaurant and diagram out the way it has to operate in order to be an efficient operation, it gets pretty complicated. So behind the scenes, the exchanges do get very complicated, and the rules that we put out in August said we want this to be a uniform, high-quality experience for the consumer. Therefore, in that part of the exchange, we want more uniformity and predictability across states. And I'm going to come back to that when we start talking about the partnerships. Finally, again, in November and December, people that keep saying, and a lot of the opposition to the ACA does keep saying, the federal government keeps acting like they're going to be really flexible about this, but just wait, the shoe's about to drop, the other shoe's about to drop. And so when the next shoe does drop and the essential health benefits are given to the states, some people pleasantly surprised, others unpleasantly surprised. People say, well, it was a surprise. It's where the law is headed and where the regulations have headed all year. So it shouldn't have really been surprising to people. But that is what I think is going to continue to happen. And if you look at other guidance HHS has put out, it's basically doubling down on the state flexibility mantra. And if you think about what the president said the other night, I think he had something less than 50 words on the ACA and something over 500 words on regulatory streamlining. That might give you a clue about what's likely to happen this year on issues about regulatory flexibility that emerge and elevate themselves to the White House. So I think you're going to continue to see, again, states in the driver's seat. States have a lot of room on these issues. And then finally I got that big bullseye. I used to try to make sure this was in all my speeches during the HHS time, and it usually was, and I want to emphasize it here. Those regulations need to be done by June of this year, and I think HHS is on a timeline to do that. The most complicated regulation probably is the risk adjustment reinsurance 3Rs regulation, and that's now over at OMB. That's been announced recently, and the other regs are scheduled to be out well ahead of July, the core regulations for the exchange. So I do think it's important for HHS to meet that timeline. Every conversation I ever had with a major stakeholder, particularly the large insurance companies, was that, we would like everything yesterday, but ultimately we need it by 18 months out. We need to know basically what the framework is 18 months out. So I learned that in my first couple weeks on the job back in September of 2010. You have about 2 years to get the final regulatory structure out, and that's what I think HHS is still aimed at. In terms of the next, I got to keep, this is too complicated for me, changing slides while I talk. And I went 2 again. There we go. Progress despite uncertainty. I told you I was on the optimistic side, so the uncertainty's got only half a page, and the progress side's got a much longer set of bullets there. Uncertainty, I think the Supreme Court is going to be 5.5 hours of argument. It's interesting, back when the case was first discussed, most of the scholars were saying that there really wasn't a very good argument to strike down the law. Now, according to the latest Kaiser poll, most people believe it will be struck down, but they don't believe it because they think the legal analysis have changed. They believe that judges are going to decide it politically and so forth. So I'm again on that score. I think in the end of the day, the judges are going to use the law here, and if they use the law, it will be upheld. But up until the time of that March set of hearings, and probably after that, because you'll have very smart people arguing very vociferously on all sides of these issues, the general feel of that's going to be, gee, there really are incredibly complicated, controversial issues with the Affordable Care Act, and it's just going to heighten uncertainty between March and June, when hopefully the Supreme Court will decide. Actually, if they did decide on the law, they might say it's a tax and put it off, but I hope that would not be good for the country to have the thing go, not be decided for another 2 years. So even, my prediction would be even in June, if there is as interest is heightened, even if the court upholds the law across the board, which 2 of the appellate courts, both written by Republican judges, have done, it will still be, there'll still be a claim of, well, gee, we said we're waiting for the Supreme Court, but now there's an election in November, and it looks like that's going to be important to the law too. So there's going to be uncertainty all the way through November. That will have an effect on particularly on the political class in the states. What are the points on the other side, though, that say states are still making progress? And here 49 states plus D.C. started with planning grants in a time when the law was a little less controversial. Every state except Minnesota and Alaska, and then the governorship of Minnesota changed and Minnesota came in, so every state except Alaska started with planning money. But what most people know that fact, but what they don't know is 29 of the 50 states have followed up planning with implementation money. All but about 6 of those are over $5 million implementation grants, and some of them are over $50 million. So there's serious money going into building these state exchanges, and that takes people in those states serious effort to put together those kind of proposals for moving their exchanges forward. Of the 22 states who haven't got money to implement the exchange, 15 of them have gotten on the other side the Medicaid exchange. We can get into this more in questions, but it's the Medicaid and the tax credits are 2 sides of the same coin in the eligibility and enrollment sector. So if you're building on the Medicaid side, that's basically building for the exchange world as well. So now you're down to a very small number of states, from more than $1 billion to 43 states, and D.C. for exchange implementation. And if we went through the other 7, all of them are in some form or fashion doing things too to advance their exchanges. More grants are pending, and there'll be another set of announcements in February of 2012. Move through these last slides a little more quickly, even though our timekeeper told us he'd be generous, but I'll still try to stay to the time. Leading states will play a key role. This is critical. I think that the single most important measure of the Affordable Care Act this year for people who are supporters of the Affordable Care Act is how many states do get across the finish line and produce something resembling the Massachusetts exchange as a success story. They won't all be lookalikes to the Massachusetts exchange, as when the White House put out their 10 states last week that they thought were, good showcase states for state progress. 6 of them were red states. Only 4 of them were blue states. They, I think, left out several of the most leading states like Oregon and Maryland. But so it's going to be a different, broad, different approach type to exchanges that will make progress this year. But there will be, progress across a broad front. And at the end of the year, I think when you step back and look at the number and the quality of the exchanges that are produced in those states that succeed, if you think about it, I don't think the Affordable Care Act passes without the vision of Massachusetts and actually the reality of Massachusetts having been implemented for a couple of years, and we've seen a couple of studies in the last few days. Massachusetts continues to have a very popular law in its state. It hasn't solved the cost problem, but it continues to be a very popular law there. And if we have more of those success stories, no matter what happens in the political world, I don't think anybody thinks that they're going to take away the Massachusetts exchange. You have 10 more examples like that this year. No matter what happens politically, that's a very significant thing, moves the country in that direction. I messed up and not moving my slides. Okay, so I skipped by my leading state slide. That's just saying that sort of what I just spoke about, the red and the blue states both will be moving forward. And again, the number of states that get across the finish line is an important marker this year of of the future prospects of the ACA. Then we move into the fact that that number, even in the optimistic scenarios, is probably less than half the states and maybe significantly less than half the states that actually fully get across the finish line. And that's a critical part of the ACA that implementation that people haven't focused on as much yet, which is that going back to June, HHS said, we don't want to have a decision here where if you don't get it completely across the finish line by the end of 2012 for the Secretary's certification, you're forever in a federal exchange mode. Let's have some middle range options, which we call partnership options for states, and those are still being worked out. There's still dialogue. Periodically, HHS says, this is how it will be, but then a week later they say, okay, we heard from some states and there will be a little more flexibility in this or that area. I think it's very much a work in progress. And if you think about what are the dimensions of that kind of partnership playing out, go back to that slide about the eligibility enrollment engine is a very uniform, predictable, prescriptive thing across the country. HHS builds a federal exchange for the states that aren't going to do their own exchanges. That's even a smaller number, by the way, than the lead states, way less than 10. But there will be some of those that say, we're just not doing it. So they have that engine available now. There's plenty of partnership opportunity for states. That's a new thing. We want it uniform and predictable for states to leverage off of that federal system. Does assume the federal exchange is going to be built, but in my year there, the one making political decisions can be difficult within the federal government, put it mildly. But building things, they do that pretty well. And so I think they will build that federal exchange if politics doesn't get in the way. It will be available, and once it is, that offers these partnership opportunities on the front end. And then what states can do is focus on the stuff that I did for 15 years as an insurance commissioner. Regulate my insurance companies, figure out how they bring product to market. Should there be standardization of products? Should we have some kind of, should we pit them against each other in competitive bidding or not? And all, how about consumer navigators, and how should what should the branding look like on an exchange? And, how do we reach out to hard to serve populations? The stuff that states, this is not a difference in kind for states on those dimensions. They've done these kinds of things for years. Different volume of that activity, but they can do that and then partner with the federal government around the new stuff, which is this very complicated front-end enrollment engine. So I think that's kind of where things could head in terms of the partnerships. And then finally, we'll have a reassessment after the election. And today, you have to say a full range of scenarios are possible with the Supreme Court and the voters both to weigh in. I will say that I think the two extremes are the least likely scenarios. Highly unlikely that the ACA, looking back 10 years from now, was written perfectly and has never been amended and worked charmingly all the way through the process once we got through the 2012 election. There are some issues in there. Probably everybody has their pet issues that probably need some new work. So there will be some changes. On the other hand, the idea that they're going to totally repeal it, as Gretchen said, good luck, even President, it's a little hard to say this, President Gingrich, but even President Gingrich, unlikely that he's going to repeal the whole law, basically there's a blocking power here, right? No realistic scenario that I've seen suggests that either the Republicans or the Democrats are going to have 60 votes in the Senate. If they don't, our history for the last 20 years has been the minority party that has 40 at least or 41 blocks anything they don't like. So that's going to keep everybody at the table trying to work out some kind of deal. So I think you're going to have some kind of rapprochement here. If you don't, good luck to the country, basically. But so then the question is, what kinds of compromises may you see? And Gretchen referenced the innovation waivers that come in 2017. Little known fact, last year, the president went in favor of Senator Wyden's bill for bumping up that deadline to 2014, and HHS is moving forward on the regs for how innovation waivers would work. It's geared against 2017, but that could change after the election into waivers sooner. So I think if we have a scenario in which we actually come together as a country, it's probably around the notion that there's more flexibility to the states. That's what a lot of what Romney says. I'm keeping it in Massachusetts. I think Massachusetts should be able to keep it, but I think other states should choose differently. That's not that far off the president's position in the big picture of things about let's let the states have more innovation power if they can get the same results. And then I think you'll see new kinds of partnership opportunities. I think we're stuck with kind of a law, whether we like it or not, and I actually think it's pretty good to have this kind of partnership where the federal government sets some basic standards, the states innovate around those standards. We have laboratories of democracy, and I think you may see new ways in which that experiment runs as well. And then hopefully we can actually as a country come together and on this issue and others achieve the glass half full rather than the glass half empty way of looking at things. Thank you very much.
When I was asked to speak on a panel about the ACA and adolescence, I was confused. By my count, we haven't even hit the 2-year mark. And then I realized that it's dog years. And so the title of my talk is If the ACA is in Adolescence, States Are Living in Dog Years. And that feels about right. 7 years worth of work packed into 1 year. And we are basically at the beginning of adolescence. And so what I thought I would try to do with the time I have with you today is balance out Joel's heavy focus on the insurance exchange, which is a critical component of implementing the law, but broaden out to the overall task confronting states and give you a sense of what they need to do and where they are. Shortly after the law was enacted, we convened the leadership of my organization. We are also an academy, and we have leaders from around the country in state government, and we asked them the question, what is it that states have to get right to implement this law and achieve the objectives that are embedded in the law and are also, frankly, the objectives that states have been working on for many years predating enactment of the ACA. And I could spend a lot of time going through this list of 10, but I do at least want to familiarize you with what states view, state leaders view as their role in implementing the law. The first you've already heard a significant amount about, which is to be strategic in your choices of building the insurance exchange. It's not just to do it, it's to do it with an agenda and some thought about what objectives you have in building that new tool. The second is to effectively regulate health insurance. There are a tremendous collection of new insurance regulations, but as Joel certainly knows, and Kim, as former regulators, these laws do not enforce themselves. There's a significant amount of energy and state attention required to assure that particularly the rating rules and the market conduct rules are put into place and don't just sit on the books. The third thing states have to get right is to simplify and integrate their eligibility systems. This is a sleeper issue. I'll come back to it later on. But most states are working from basically a welfare platform of eligibility that was built around aid to families with dependent children, transformed to TANF. That's also the engine for Medicaid. Medicaid dramatically expands under the ACA. Millions of Americans become eligible for a tax credit, and we don't want to, and we don't have the administrative capacity to push people through such an antiquated eligibility system, so we have to focus on that. The fourth thing states have to do is expand provider and health system capacity. Again, we know from research that people without health insurance get about 60% of as much care as those who are insured, and that means that with the expansion in coverage, we would expect more demand for services, and if we can't meet that demand, what good have we done? The fifth thing states have to do is look at benefit design. We added this to our list before we knew that HHS was going to give states as much flexibility as it has around the essential benefits. But even beyond the essential benefits, states have to make decisions about Medicaid benefits. They have to make decisions about their own employees and retirees. There's a significant number of benefit issues that rest with states. The sixth thing states have to do is to emphasize care coordination. There are great opportunities within the law, whether it's building patient-centered medical homes, whether it's all the work around dual eligibles, Medicare and Medicaid. This is an area that requires a significant amount of effort, and yet many view it as a key component of the potential for cost savings. The seventh thing states have to do is use data. Again, a significant amount of new data collection embodied in the law, access to services, linguistic competency of providers and primary language of the population being served. The question is, are we going to do anything with these data, or are we just going to collect them and have them sit somewhere? Are we actually going to use them to drive improvements in policy? Which leads to the eighth, which is to pursue population health goals. Again, you heard some about that earlier today. There's the prevention fund, but many other aspects of the law that have the potential for actually affecting the health of the population, and there are opportunities, if you embrace the law, to set some goals at the state and local level for improvement, and that's a part of achieving what the law sets out to do. The ninth aspect is engage the public in policy development and implementation. We know, we've talked about it earlier today, people don't know a lot about what's in the law. They feel distant from government, and public engagement is a critical component of implementation. Our final on the list is to use basically all of those 9 to demand quality and efficiency from the healthcare system. So this is sort of the state leaders' list of what does it take to turn this law into the opportunity for improvement that it's designed to be. And what I want to note as you look at this list, whenever you make a list, something's first and something is last, but from the perspective of our leadership, what you want is a balanced approach. Many people are putting most of their attention, the news attention, the dollar's attention, is on the right side of this balance, which is insurance exchanges and eligibility systems. But if you want a sustainable system, if you want to meet population improvement goals as well as coverage goals, if you want to look at how this can actually transform delivery of care, you need a balance between the delivery system improvement, provider capacity, other sort of population and delivery system-based aspects and balance that with the coverage-based aspects. And unfortunately, from a state perspective, what we're observing today is that the federal dollars directed to states, and Joel discussed some of these, are very heavily balanced on the coverage side. So there's a significant level of support, as Joel described, for states to bring up insurance exchanges. And they need that support, don't get me wrong. There's also 90-10 matching funds for revamping your eligibility systems. There's tremendous federal effort going on delivery system, the ACOs, a lot of the Medicare-driven work. But in terms of supporting states in state-based agendas for system improvement, there's not a lot of federal resources flowing to states. And so we see an imbalance when we look out to the states and say, what are they working on? We see an imbalance. How do we see it? Well, in a academically oriented meeting like this, I have to pitch a tool that my organization has created called State Reform. It's a learning community among states. And what do we have? I just checked. We have almost just shy of 1,000, 939 documents that are state-generated documents. They're RFPs, they're work plans, they're agendas for meetings, they're survey results, they're applications for funding, all associated with implementing the law. We've broken state roles implementing the law into about 100 what we call milestones, and we are tracking whether or not states are achieving those milestones. We have almost 2,000 people registered to participate in this community. And this is not the only way, but it is one way to answer the question, what are states working on? And so if you go into state reform, which is at www.statereform.org, surprise, surprise, if you go to the insurance exchange page, you'll find over 300 documents that states are sharing with each other to help them learn how to do the job of bringing up an exchange. And if you look at a map of how many of the milestones states have passed in bringing up the exchanges, you see activity all over the country. You see a number of states at about the 50% mark, which, given that these have to be up by 2014, is a very significant progress. But if you look at some of the delivery system aspects, this is the page, for example, for using your data, one of the areas that we know is important. We only have a couple of dozen documents that states are sharing with each other to show how they're planning to use the data. Or in a critical area that states know they have to work on, this is the state progress map on improving provider and health system capacity. And, you know, states are mostly in the teens. It's just not an area where there's a great deal of work going on. And so the question is why? If we know that we have to do all of this to succeed, why isn't it happening? I want to go through a list of the barriers states are facing in implementation. Some of these will be obvious, but hopefully some of them will prompt some new thoughts. The first is fiscal capacity. I hope, know that states are going through the worst fiscal times since the Great Depression. There is good news each quarter. We are digging our way out of it. But just as states are lifting themselves out of the trough they've been in, the federal additional support from the ARA funds that gave a higher match rate to states in their Medicaid program phased out at the end of June of last year. And so state budgets are still in very tough places, and there just aren't dollars to spend on anything that isn't essential. Having gone through a few bad years, states are doing layoffs. They find it very hard to hire expertise. Smart people like Joel go work for Manatt, which is a good choice for him, but it's tough on the states. It used to be that when we were trying to schedule a meeting, one of the biggest constraints in finding a date people could come for a meeting was furlough days. Well, I can't meet on Friday because we're not working that day. We're not getting paid. A third barrier is the fact that the fiscal pressure on Medicaid is so intense that basically all of the state energy that isn't devoted to implementing the ACA is going into figuring out how to make the least harmful possible cuts to Medicaid over the next 2 years, given all the constraints that you face around maintenance of effort at the federal level. This is occupying every ounce of energy, and if you're in California, even when you make those tough decisions, you then go to the courts and you refight those battles over again. Joel mentioned the information technology systems. As every state is trying to build new systems, the IT vendor community is very happy, but it turns out that there actually isn't even enough capacity in that community to meet all the needs that states have. And then, of course, there's the politics. Half the states are suing the federal government. They don't want to be a part of the law. And it used to be, early on, the sense was if you don't like the law, you sort of grudgingly do it. Now, this is the line in the sand. We are not going to do anything that has anything associated with Obamacare, and that polarization is clearly going to be in place all through 2012, through the election. Gretchen talked about uncertainty. She said I would talk about the Medicaid lawsuit, which I wasn't planning to do. It is meritless. Okay, that's it. Anyway, so, but I will say that the uncertainty, there is real uncertainty, but there's a lot of there's a lot of uncertainty for political reasons, meaning it's convenient that it's uncertain. Well, we have to wait for the Supreme Court. Well, we have to wait for the election. And my biggest fear, and I'm afraid it will be realized, is that some combination of the Supreme Court decision and the election will not be crystal clear. And so everyone who's saying it's uncertain will find that even after these two milestones are passed, that it's still uncertain. Maybe the court throws out a portion and is unsure about others. Maybe we have, surprise, surprise, divided government even into 2013, and no one knows what the president and Congress will do. Uncertainty is a convenient excuse for not moving forward beyond even the real uncertainty. And I hesitate to, but I think it's important to list the last barrier, which is the possibility that we're even having excessive deference to states. As a state-supporting organization, we always say, give us choice, give us choice. But frankly, states are suffering with the number of decisions they have to make. And particularly in a political environment where there's a lot of opposition, every choice is an opportunity for delay. And given the limited capacity, analytic capacity, to work through tough issues, every additional choice is how many resources can we put to figuring out what our risk adjustment system should be. And so there's actually, despite the value of that deference, I think there's one of the barriers is how many choices states are having to make. So let me just close with an example of where I think these barriers come together. Let me take on, instead of exchanges, which Joel talked about, I want to talk about eligibility and enrollment, an area that my organization spends a great deal of time on. Here's the federal vision in the law. You have Medicaid eligibility below 133% of poverty. You have tax credit eligibility through the exchange, purchasing coverage through the exchange for people up to 400% of poverty. That is a perfectly seamless system at the top, and then you, if you're in Medicaid, you go find a Medicaid plan. If you're in the exchange, you have an exchange plan. That's basically the minimum vision under the law. Now, if you're in an ambitious state, a state that's really embracing the law, you're saying, I don't want these. I don't want integration. I don't want a connecting line. I want real integration. I want one eligibility system. No matter where you start, whether it's with an insurance broker's office that you walk in, or a community-based organization, or a county office, or sitting down at the internet, you're going to get the same eligibility system that is going to determine your eligibility. And then when it comes to plan choices within Medicaid and within the exchange, we're going to be strategic. We're going to demand the same data, the same accountability, the same reporting standards. Yes, the choice of plans will be different, but there will be continuity, because remember, people are going to be moving between the exchange and Medicaid every day. So if you're a state that really embraces the law, this is your vision. But this is what we're likely to see in many states in 2014. A Medicaid eligibility system with a rotary phone attached to it. An exchange eligibility system that it's at least at the level of a fax machine. And those two are going to have to talk to each other. And it's not going to be instantaneous, and it's not going to be integrated, and it's not going to be seamless. And then they will lead to two very different systems. That's the likely reality. This is not terrible, but it is not the ideal. And I think one of the issues we need to confront as a country is that given the degree of the scope of change we're trying to put into place, we're not going to see the ideal on 2014. And I think this will play out, versions of this will play out in many aspects of implementation. So I would just conclude by telling you that there are two conspiracies afoot. The first one is that supporters of the law are pretending that it's going extremely well and there's really nothing wrong, nothing to worry about. The glass isn't just half full, it's completely full and it runneth over. And there are a few challenges. And that, because in this political environment you don't want to admit that anything is other than perfect. And that is one of the conspiracies, and I see conspirators all over every day. But there is another conspiracy afoot, and that is that the opponents are pretending that they're not implementing the law, and that is equally fallacious. The fact is there is a tremendous amount of work going on around the country in every state with one or two exceptions. Often, because of the politics, it is below the radar screen. They cannot talk about it, but there is a tremendous amount of progress that states are making. So neither of these conspiracies captures the truth. You really have to look at them both together and understand that we're at a very complex time, but there's also a tremendous amount of progress being made. So my closing thought to you is that the Affordable Care Act is actually not in its adolescence, the title of this session notwithstanding. It is in its infancy. January 1st, 2014 is a critical date. There have been some before it. This is probably the most critical. There will be others after. And what I really look forward to is to coming back to the NASI meeting in 2022 when the ACA really is in its adolescence and talking about what the status of the law is at that point. Thank you very much.
Well, thank you, and I know you all have your questions. We've got about 25 minutes, and just to give you a few minutes to think before you head up to those microphones, because I know you have plenty you want to ask this great panel. Let me start it off by something I was thinking as I was listening to all of those, and frankly, as Mr. Rother was closing up, I thought his comments about the complexity of the system was certainly evident in the past panel, and the finer point was put on that today. The true enormity of this shift, not only from a social but economic standpoint and just the systemic standpoint, is just beyond comprehension in many respects. My job, as I mentioned to you, is the head of state affairs, which means I get out beyond the Beltway. There is life there. And I'm just going to tell you that the further you get from the Beltway, the less familiarity people have. I mean, we talked about, and you heard the comments about how little people truly understand. And I have the benefit and opportunity to speak to a lot of groups that you would expect to be knowledgeable, like insurance brokers, about what an exchange is, and I'm going to tell you they don't. So here we're going to enter in, we've heard all of the challenges being presented by lack of resources, the complexity, the enormity, the uncertainty. But we're going to be faced in a very short period of time in those dog years, Alan, with having to inform a public about you have to enroll. I mean, you're going to have hundreds of thousands of people that for the first time ever will be enrolling in a health plan, whether through the Medicaid expansion or whatever, that have had really no meaningful exposure to a process. And yet we could have varying degrees of success and rollout taking place within the states or at the federal level. So I was hoping that each of you might address that issue from your own perspectives, the challenges of communicating with the constituencies that you serve or recognize, and whether the timeline that we're talking about is actually realistic to accomplish the goal of reducing cost and ensuring access. And then we'll have you all come to the mics.
Well, as usual, Kim, very good question. What Kim didn't mention, why we know each other well, is because Oregon, Pennsylvania, Oklahoma, we sat next to each other for all those years at the NAIC. She always asks us difficult questions, but it's absolutely a big concern how we're going to educate everybody about these choices and these options. And I think that's an area where, thank God, we do have this be more of a state-based thing, because I think a lot of that is going to build on what frameworks already are within the states. There are plans to have national campaigns and that sort of thing, but a lot of this is going to be at the local level. So I do think it's a big challenge. It's going to take a cooperation of people on all kind of different dimensions. Again, this is not part of the ACA that's new. There have been in almost every state some kinds of programs tried one time or another, CHIP rollouts, Medicaid expansions. In Pennsylvania, it was, adult basic. In Oregon, it was the FIAP program. So there are all kinds of models for how to do this, but this is going to be at a bigger scale. The other thing I would say that I think is important here is, thank God we are in an age of the internet, because none of this is even fathomable without the virtues of a web technology. And so, somebody was talking to me today about the written application and how that's going to work. And it's like, if you go in category A and then you go to B, but maybe you go to C or maybe you go to D. I said, you know what I'd do in a state? I would bury that application as deep as possible, and I would be saying to everybody, please don't try to do it on a written application form. Please come talk to somebody. If you don't have web access yourself, then go work with somebody who does, or call on the phone to somebody who will be sitting at a computer screen, because all of these issues about communicating information are just light years easier in a web-enabled world. And then people say, well, what about old people? And I say, I don't still have a great facility with the web, and I'm going to have to learn more. But I still kind of look at it, and then I want to go to the store and buy and touch the product before I buy it. That's not how my kids operate. They basically just look at the web and they're done. They purchase something. They trust it completely. So this is going to take time. By 2013, there'll be that, Ellen, some of you, the rest of us will have aged out of the marketplace, and more people will be web enabled. Every generation is going to get better at this. And my vision is, in the future, it'll be, you know, the mother who wants to access the program doesn't know whether she's Medicaid eligible or exchange eligible, but figures she's probably doesn't have the income to buy it herself, will ask her kid, if not herself, for his smartphone, and she'll go there and she'll have exactly the same access on that smartphone to her health care choices that the richest person in Westchester County has on his smartphone. So that's the future I think we're headed to, but it's going to be rocky between now and then.
Well, I think we know from Massachusetts that actually the timelines in the ACA are longer than they should be. I mean, you can do this fast, you just have to want to, and that's part of the problem. I take a lot of examples about how this is going to roll out from either CHIP or Part D of Medicare. CHIP is the one I'm more familiar with in the broader sense, and I think we know from a program like that, that as much as we know people want it and need it, it takes a long time for people to know what it is, to trust it, to learn how to access it. I think the estimates of how quickly people will avail themselves of these new opportunities for coverage are wildly optimistic because it just takes time. People don't live in the world we're living in of talking about this every day, thank God. But the question then really is at some point, as has occurred with other programs, even after challenging starts, is there a sense of stability and a sense of commitment and a sense of ownership? And I think one of the interesting political dynamics that's played out in the last year is that we often think about the partisan split, but at the state level, what we often have is an executive legislative branch split, where the governor, even a Republican governor, is very nervous about poor implementation of the law because on January 2014, that governor is going to be accountable for how the state is functioning, whereas the legislators are like members of Congress. They just have to talk. And if they want to make a political statement that they don't like the law, they make that statement, and there's no consequence to them. So there's a real difference between owning the human interface and the complaints that you're going to get when this thing doesn't work very well, and making a rhetorical comment about whether or not you think it's a good law. So I think if we get to a stage of ownership, then the owners will be motivated to act in a very different way than this environment where there are so many people who feel like they don't have that ownership.
Yeah, I guess from the large self-insured employer standpoint, we obviously aren't concerned about the state implementation. Our plans are in place now. We have a couple of concerns. So one is that our employees clearly get confused by what's happening in the exchanges versus, what are you eligible for in your employer's plan. A good case example was when the law changed to allow employees or children to come on their parents' plan up to age 26. The announcement was made in the summer, and most of us don't change our plan until the next plan year. So we had a lot of employees calling. So we have that sort of level of confusion. But I guess the broader point I would make was what the president said when the law was passed, which is you should be allowed to keep the plan you have. And I think this is a good example of why, because now you have 160 million people covered by the employers' plans. This to me is kind of a foundational security for an awful lot of people in the United States while everything else is in flux.
So do we have questions?
Hi. Linda Flowers from the AARP Public Policy Institute. And thank each of you for your presentations. They were very informative and very entertaining, so that's a twofer. And my question is for Alan. You outlined all the things that state Medicaid agencies are thinking about as they're bringing up the program, and it sounds a little bit overwhelming. And then you talked about the state furloughs and hiring freezes, et cetera. And we know that in addition to the ACA, states have to continue to run their programs. And we also know that states are contemplating putting very vulnerable populations into managed care. All of this happening simultaneously. It keeps me up at night worrying about how is the state going to meet its legal obligation to manage its program and ensure high-quality, safe care is delivered to all beneficiaries. I wonder if those are some of the conversations you're having with states and what you might be thinking and hearing about that issue.
This keeps me up at night too. This is probably the most underreported and understood, if that's certainly not a word, phenomena, and I think it's unfortunately, what you're describing has basically nothing to do with the Affordable Care Act, and so because it has nothing to do with the Affordable Care Act, no one cares about it. We are, as you said, around the country, state by state. There's a long history of relying on private managed care companies to manage care for people in Medicaid, and by and large, the populations enrolled were moms and kids, low-income families, and we have a pretty good data to show that that was on average, a small net improvement in access to care for that population. When we talk about the population now being moved into managed care, we're talking about elders and people with disabilities, children with developmental disabilities, and when we say disabilities, we're talking about, we're talking about severe enough to make you eligible for Medicaid, which means traumatic brain injury, serious and persistent mental illness, HIV and AIDS, physically degenerative diseases, and we just, the whole ACO and quality movement doesn't really have metrics that work for this population. We don't know how to assure that people have high quality care. And so this is sort of a grand social experiment without an IRB, here's the problem. The problem is the fee-for-service system that's been serving this population hasn't exactly demonstrated itself to be so fantastic either. We know there's a lot of lack of coordination. We know there are a lot of people not getting services they need. And so you don't want to hold up the fee-for-service system as some great thing that we're taking away. But there's a tremendous amount of risk involved in this shift. And I'm afraid, I don't know what to say other than that it is occurring at such a rapid pace that there's no way really to have evidence help guide the course, because we're doing it faster than we can get much in the way of results out of it.
Yeah, hi, Lee Goldberg with NASI. Two questions. One is, we heard earlier from Dr. Smedley about preventive benefits and some of the promise that could have on the impact of the healthcare system. I wonder if any of the states that any of you have been working with are far enough along in the necessities to tackle some of the opportunities for preventive benefits. So that's one question. And another really unrelated question is, let's say the exchanges get off the ground in 2014, they're working well for a couple of years. People in their 50s are going to have 5-10 years of exchange experience. How will that change their view of Medicare when they get to that?
I don't know specifically around the preventive benefits. I think in general, the exchange challenges enough for people that the kind of walk before you chew gum approach is pretty much what most states are about. And so most states today, even just generally about essential health benefits, I think are looking very carefully at what are those 10 designated plans, and maybe more specifically at what's the default one, because the way this is going to line up in my state, we're probably going to have to start telling people pretty early on that if you guys can't all figure out how to come together on this, we're going to end up with the default. And so what is that default? So that's the level of discussion that I hear primarily on that. I think on your other question, it's certainly interesting that the dialogue about, a premium support system in the Medicaid side of the world it certainly brings up images of what these exchanges are for the non-Medicare world and how those things are going to eventually be put together. I think you're going to start to see conversation about that. I know there was some dialogue between Henry Aaron and somebody else about kind of how those two things connect that I was looking at either yesterday or today. So I do think there's obviously these kinds of relationships in there, but then there are huge questions about, what is the bottom line? It's pretty hard to go from where we are today to a defined contribution. Obviously, I can't even get my arms around what that could possibly mean on the Medicare side of the equation, but some form of, using an exchange-like concept, which you already do in Part D, obviously. If the exchanges work, I think there will be more of a blending in those kind of directions with some kind of, bottom line security still attached to, for certain populations, elderly and the groups that Ellen was just talking about.
Can I just say a word? You didn't actually ask me to lead, but I'm going to say something anyway since wellness is one of my favorite topics. But my employers, large self-funded plans, have been very excited for the last decade or so about instituting new wellness and prevention programs. It's a classic kind of win-win, costs go down, employers get healthy, employees get healthy, et cetera. But the last, say, 2 or 3 years, they've really stopped now from pursuing those programs at quite the pace they were pursuing them before. They've got to the point where a lot of people are using health risk assessments, starting to use some sort of incentive for filling those out. But the government regulations have been so onerous with response to programs that we really that won't allow us to implement incentives and participation programs, that a lot of people now are pulling back. So I think the progress, if anything, has been a negative sense of progress now.
Thank you. Thank you for waiting.
Hi, my name's Rob Nelb, and I'm actually with CMS, and I'm actually my day job to work on some of these exchange regulations from the Medicaid and CHIP side. And so we're kind of in the throes of figuring out that right balance between requirements for the states as well as state flexibility. And Alan and Joel, I kind of felt like I heard conflicting ideas about how much state flexibility to give, and I was hoping you could talk a little bit about it more, and particularly if the next Congress ends up extending state waivers even earlier. What parts of the law do you think we should allow some flexibilities, and what parts of the law do you think we really need some common ground rules for everyone to follow?
I have to start. I guess I start. I do not. I think this is one of the hardest issues. I spend a tremendous amount of my time on this topic. First of all, I think the global waiver issue is a little bit overstated in the sense that at least when there was the little political flash in the pan, I was in the headlines for about 2 days, this notion of, well, we're going to let states do this in 2014. And I mean, the number of people who thought this was like an opt-out option for states, or, this is basically, that provision was basically designed for states that want to do something more akin to single payer, that don't want to have this private market exchange-based thing, but can still feel that they can achieve the cost and the coverage standards of the law. I think one of the realities that we're a non-partisan organization. I can tell this is a non-partisan audience by which jokes get laughed at, but I think we have to acknowledge that as of today, we do not have a conservative model of universal coverage that we can compare to the more liberal model of insurance coverage. And when I was in Arizona, and the legislator said, we believe in market-based solutions, and I'm thinking, well, what is the market-based solution to the fact that a family insurance product costs $15,000 when a family makes $45,000? I don't know what the market, well, I guess the market solution is you give them subsidies and you have them buy a private plan, but that's what we're doing and they don't like that. So I genuinely don't know what the range of options, could be that would be acceptable to those from a more conservative vantage point. I think on the broader issue of state flexibility, a couple of thoughts. The first is, it's really different to have state flexibility around sort of the values or the market conditions of the state and things that require a lot of technical analysis and consideration. And I think that's part of where states are really hamstrung right now, is that if you're asking states to make complex technical decisions, then they don't have a lot of capacity to make those. Whereas if you're asking, would you prefer it more this way, more that way? I think even though that can be hard, that's more consistent with what value we can get out right now. And I also, I guess we just have to also acknowledge that part of the flexibility dynamic right now is the politics of flexibility, which is wanting to say this is not one size fits all. This is, states really do get to tailor this, and some of that's a substantive desire, some of that's a political desire. So I don't have any good answer. Those are some meandering thoughts.
I don't have a good answer, but just a couple of thoughts on it. One is that I'd like to paint the scenario of the exchanges as, you know, the Brandeisian laboratories of democracy, and eventually the best practices will win out, and all states will move in one direction or another. And there are kind of, you know, there is on the exchange side more conservative vision, more liberal vision. Somebody once said to me, so is that how you describe the 40-year history of Medicaid? And you know, well, actually most of the time when I say that, people laugh. So yeah, we do see something about this audience, but it's painful because people should laugh at that, because Medicaid wouldn't be described as 40 years of successful innovation and then states rising to the best practices. It'd be defined by 40 years of the federal government fighting with the states and kind of, you know, states trying to evade in this and that way and so forth. And they're painful discussions that I see. My sympathy is with you inside the agency to try to wrestle with the ways in which the federal government tries to keep control of this program, where the states also have skin in the game and so forth. So if I was czar of the universe, I would force the equation one way or the other on Medicaid. I would say, let's go to block grants if you can win that in the field of public opinion. That would not be my vote. I don't think that's the right way to do it, because frankly I don't trust, you know, the states to be able to handle the most vulnerable populations. I certainly don't trust the insurance companies, having regulated them for 15 years, to manage those. It's a little bit, they're not too much different than trying to manage, you know, an 88-year-old with 3 chronic conditions. It doesn't work in the insurance model. So I would go the other way, which is I'd try to figure out some way to up the ante and say, we can't have this back and forth and all this energy wasted on, you know, provider taxes and other ways of trying to, you know, get as much money on the federal side of the equation. So let's make this grand bargain. Let's say the federal government pays for Medicaid and the federal government gets control of the program like they have control of Medicare and is an efficient purchaser in the marketplace. Then I would go use Medicare Advantage type things very carefully. But I think somehow we can't keep Medicaid like it is. Somehow we have to find a way to solve it, because, you know, it's just not working the way that it should, in my view.
Thank you. Gretchen, any further comments?
No, can I ask a question?
Of course.
So and this is probably really more a political question than anything, but particularly Joel, do you think that the Affordable Care Act would be more effectively implemented if it had taken a slower trajectory? Remember, right after Scott Brown was elected in the Senate, and I think that Rahm Emanuel was suggesting to Obama that they pull back a little bit and sort of enact a very small, you know, reform rather than go for the more global reform. Would that have been a...
No, absolutely not. I think, you know, Peggy Noonan said that in a column in the Wall Street Journal. The president had just gone after, you know, eliminating pre-existing condition exclusions. You know, then we could have seen how that worked and then moved to the next step. And Huey Reinhardt had a column a few days later in the Wall Street Journal saying, gee, Peggy, I'll take you at your word. So first we'll do that. Okay, well, now we got all the sick people coming into the market, none of the healthy people. So this isn't going to work out real well for the pool. So, gee, we'll have to, in order to make that ban on pre-existing conditions work, we'll have to have a mandate so that everybody comes into the pool. And now that we've got a mandate, we either have to let the poor people out of it because they can't, it would be a cruel joke to impose it on them, or we have to give subsidies, and we really can't afford to let people out of the mandate, because guess what? There will be people who pay 30 to 40% of their salary for coverage. Those will be the people that are already paying 30 or 40% of their income. So you're going to get, so you have to have the subsidies in order to make the mandate work. And then, gee, by the time you're there, you say, there's a lot of new people in the system. Are there any ideas for how to handle a high volume of new people? Gee, that exchange idea kind of seems to be part of it. And so just saying you want to eliminate pre-existing conditions basically gets you into the logic of this whole set of reforms. Atul Gawande has a great article about that. And then I think the other piece that we haven't solved is the cost issue, and I think we're basically at a national level doing just exactly what Massachusetts did, which is if we can get into the humane part of the world, which is all the rest of the countries that actually provide basic security for people, then you take that issue off the table, and then you can actually have the cost control discussion. If there's one thing that's driven me crazy in the last year, it's this idea that people have, well, let's see, so we're going to add all these people to the system, and then we're also going to figure out how to control costs, and they roll their eyes. And it's like, well, if you actually look around the world, the two things are actually totally integrally related in every other country in the world. First, you get everybody covered, then you have a more rational system. You don't have all this crazy fragmentation. We have to figure out how to do that in Medicaid, and then you actually can deal with cost control. And we haven't solved it. Massachusetts hasn't solved it, but to my mind, what Weil, Patrick, and the crew in Massachusetts are trying to do around cost control is a more sophisticated discussion than we're having in any other state in the country. So
Thank you. We have two people. We have two quick questions, and so two really quick answers, okay? Yes, sir.
are you saying those weren't short answers till now?
For you, yes. But no.
Hi, I'm Mike Collins. I'm on the office of Congresswoman Corrine Brown. She's a Democrat from Florida. Hope this question isn't too narrow or too pointed, but I had a room full of lobbyists in my office yesterday, and I'm going to have to advise my boss. I have access to experts. I'm going to use it. There's a bill moving through the House that's got 160 co-sponsors, probably 170 by the time I'm done talking, mostly Republicans, but a fair number of Blue Dog Democrats, to exempt insurance broker commissions from the MLR. Could you comment on the wisdom of that sort of legislation? Thanks.
I don't think that's likely to pass because it essentially would add 5% to the cost of health insurance.
Good answer, Joel.
That was quick.
Thank you. That was quick. Thank you very much. Yes, ma'am. Please.
My name is Renee Landers, and I teach at Suffolk University Law School in Boston. And I guess I wanted to go back to something that Alan said about, what is the alternative to trying to do this exchange approach to, at least as a first step in trying to address this problem. And isn't one of the answers that, and this probably, I'll get hissed out of the room maybe, or maybe not, that the market has had about 50 years to try to address this problem, and it hasn't done it. And so now we need to try some other things.
Well, I mean, the normal retort to that is, well, we don't really let the market work, and I mean, so one of my favorite slides I didn't put up, and maybe this is a good way to end. So I'll do a slide like this. Okay, it's from the Kaiser Family Foundation. They polled 4 groups: attendees at the Republican National Convention, attendees at the Democratic, delegates of the Democratic National and Republican, and then Republican voters and Democratic voters. And I'm going to get the exact words wrong, but it basically says, which of these two is more important, assuring that everyone has health insurance or keeping taxes low? And the Republican delegates are 95-5, keep taxes low, and the Democratic delegates are about 80-20, or maybe not. It's you get the point. Right. Similarly, 90-10, give everyone health insurance. And of course, the voters are less polarized, but still quite divided. So I think the problem with all of the conversations we're trying to have is that people are defining the problem and the question differently. So what do you mean the market's failed? 180 million people have employer-sponsored coverage, and employers like doing it. Isn't that right? And they think they're doing a good job. And you have insurance, don't you? You work for a large university. And so I think we're looking at the problem differently. And it's very hard to say, well, can't we all agree on the solution, when in fact it really begins with fundamentally different senses of what the problem is. And I think this political season is showing that even more, that if the problem is the deficit, if the problem is the size of government, if the problem is the role of government, then that's a completely different frame for asking what's the appropriate next step than that the problem is there are 50 million people without health insurance, and even those who have it are paying more than they should have to, and it's uncertain. They're just two really different ways of thinking about the nature of the problem, which makes it very hard to agree on any sort of solution.
That's good. Thank you.
Thank you. Thank you for that question. And won't you all join me in thanking this wonderfully thoughtful and intelligent panel. So hold on to your seats.